why don't we go ahead and get started? And I think I'm going to share my screen just for a minute while I introduce our lectureship and our lecturer very briefly, and then I'll hand it over to Dr. Vogel. So we're here today celebrating Dr. Henry Swan. This is the 39th annual Swan Lectureship, arguably the most prestigious lecturer of the year in the Department of Surgery. And we have an extremely distinguished surgeon, Dr. Julio Garcia-Aguilar, who will be presenting today. And again, I'll let Dr. Vogel introduce him in detail. But just a few words on Dr. Henry Swan. So Dr. Swan was a native of Denver, and he trained at the very top institutions, including the University of Colorado and, oh, by the way, Harvard, and made his way back after serving in World War II, back on faculty at the University of Colorado. And I think the timing between him being appointed assistant professor and chair of surgery was a couple of years. And he obviously quickly rose to the ranks and took the reins of this department and was really the first full-time chair of the Department of Surgery. His area was cardiac surgery, and he was the one who did all the preclinical work on hypothermia, cooling patients down, and stopping the heart, and being able to do open heart surgery. So he was one of the first people in the world to do open heart surgery. Of course, this was before heart-lung bypass, and all of his operations had to be accomplished in about 6 or 7 minutes. But this brought a lot of fame to the University of Colorado, and people from all over the world came here to learn about hypothermia and these techniques. So obviously, we're very proud of Dr. Henry Swan, and we reserve this lectureship for the most distinguished surgeons from around the world. And with that, I'll have Dr. Vogel introduce Dr. Garcia-Aguilar, and I'm going to stop sharing here.
Thank you, Rich. It is truly my honor to welcome Dr. Julio Garcia-Aguilar to the University of Colorado Department of Surgery Grand Rounds. I could really not think of a more qualified person to provide us with an update on the multimodality treatment of non-metastatic rectal cancer. To give you some background, Dr. Garcia-Aguilar received his MD and Ph.D. from the University Complutense in Madrid, Spain. He completed his general surgery residency at Beth Israel Hospital in Boston, Massachusetts, and a colorectal surgery fellowship at the University of Minnesota in 1993. He currently serves as the professor of surgery at Weill Cornell Medical College and the Benno C. Schmidt Chair of Surgical Oncology and Chief of Colorectal Surgery at the Memorial Sloan Kettering Cancer Center in New York City. He has been a National Cancer Institute R01 funded investigator for 12 years with total awards in excess of $9 million. This funding has supported the timing of rectal cancer response to chemoradiation and the organ preservation in rectal adenocarcinoma trials. He was also the lead investigator of an American College of Surgeons Oncology Group's study to understand the role of organ preservation in rectal cancer. Dr. Garcia-Aguilar has led or participated in studies that have had a direct impact on our management of rectal cancer at the University of Colorado Cancer Center. His 2015 Lancet Oncology report that demonstrated the benefits of extended courses of neoadjuvant chemotherapy in stage 2 and 3 rectal cancer was a key factor in our decision to adopt total neoadjuvant therapy, or TNT, for these patients. The value of TNT is in cancer downsizing or downstaging, and in many cases, complete disappearance of the cancer. Building on the work of Dr. Habergama from Brazil, Dr. Garcia-Aguilar and colleagues showed us that when TNT leads to complete disappearance of the cancer, non-operative management is safe and durable. Following his lead, our cancer center has selectively adopted this approach for patients with complete clinical response to TNT And we are now actively following around 20 patients who presented with stage 2 or 3 rectal cancer and have been successfully managed without surgery. These are obviously very grateful patients. Finally, as leader of the Organ Preservation and Rectal Adenocarcinoma, or OPRA trial, Julio has presented preliminary results indicating that the majority, about 60% of patients treated with total neoadjuvant therapy for their rectal cancer can be managed without surgery. I expect that we will hear more about this important trial today. So as I mentioned previously, and I think you will agree, when it comes to rectal cancer surgery, clinical trials, and evidence-based and innovative patient care, simply stated, Dr. Julio Garcia-Aguilar is the man. On behalf of the Department of Surgery and the providers in our cancer center, I welcome Julio to the University of Colorado and to our grand rounds. We look forward to your presentation. Thank you.
Can you see my screen?
Yes, we can.
I just want to start by thanking Richard and John for inviting me to share some time with you today, and also for that generous introduction by John. We're in the middle of a blizzard in New York, and I'm sure we have as much snow here today as you have in Colorado, but I don't think we will be able to enjoy it as much. I guess it's a great and very distinct honor to be the 39th annual Henry Swan Visiting Professor in Surgery at the University of Colorado. Looking at the list of the past Henry Swan Visiting Professors is intimidating. It includes some of the most prominent surgeons from the last 40 years. I accept adding my name to that list with immense gratitude and humility. Although my clinical research and research interests today focus primarily in colorectal cancer, I had enough exposure to cardiothoracic surgery during my training years to appreciate the significance of Dr. Swan's contributions to the field and the surgical skill required to perform cardiac surgery without cardiopulmonary bypass. I doubt that many surgeons today will have the speed and precision to conduct this type of surgeries in such a record time. But while I can match Dr. Swan's accomplishments as a surgeon, teacher, and leader, I can relate to Dr. Swan in a couple of ways. First, by sharing an interest and determination in pushing the field forward and trying to improve the outcome of our patients. And the second one, and more mundane, is our birthday. I was also born on May 27th, several years away from Dr. Swan, but I share a birthday. So I think from now on, every May 27, I will think of him and I will remember these special events. So again, thank you so much. So my presentation today is gonna focus on, of course, on rectal cancer, and I'm gonna give you some overview of some of the pursuit of the optimal treatment of rectal cancer going back to the old days. These are my disclosures that have not much to do with what we're gonna talk about today. And this is the outline of my presentation. I'm gonna give you some historical vignettes about the early treatment of rectal cancer. I'm gonna give an overview of how we have evolved in the use of radiation in rectal cancer. I'm gonna give you some thoughts about and present some evidence about the use of adjuvant chemotherapy in locally advanced rectal cancer. I'm gonna touch upon the rationale and some of the evidence for the total neoadjuvant therapy. And finally, I'm gonna just talk a little bit about the watch and wait strategy for organ preservation in rectal cancer. Now, the history of rectal cancer is interesting because of all the most common type of cancers, the rectal tumors are accessible. So the human have known about rectal cancer for a long time. It was very difficult to make the diagnosis of a pancreatic tumor or even colon cancer, but rectal cancer was relatively accessible to very unsophisticated exams. So surgeons have known about this condition for a long time. That's the reason why the history of the treatment of rectal cancer has such a big impact on the history of surgical oncology. The early attempts of removing the rectum from the perineum date back to the 18th century, but it was not until the early 20th century, after the introduction of the colostomy at the time of the Napoleonic War, where surgeons really attempt systematically to try to remove the rectum in patients with rectal cancer. And the first operation was called the perineal excision of the lower part of the rectum, the extraperitoneal portion of the rectum. Surgeons will create a colostomy and then they will go later to remove the rectum through the perineum. That will leave on most patients a major perineal wound that never healed. Something similar can be said about the transsacral resection popularized by Cocker and Krusky at the end of the 19th century. Ernest Mile in London performed a kind of in-depth analysis of his own experience with this perineal excision of the rectum and found that of 57 patients that he treated, 95% had recurrence within 3 years. He analyzed the recurrence to try to improve the operation and realized that most of the recurrences occur at the pelvic peritoneum, in the mesocolon of the pelvic portion of the rectum, and at the nodes of the bifurcation of the common iliac vessels. So based on that pathological information from studying his own patients after they die, he designed the operation that bears his name, the abdominoperineal excision of the rectum. And you know what that operation entails: ligation of the inferior mesenteric artery and removal of the upward spread of the tumor, detachment of the pelvic mesocolon and mesorectum from the concavity of the sacrum, sharp division of the lateral stalks, and wide excision of the skin. We are all familiar with that. But that operation was a phenomenal operation. At the beginning of the 20th century, the patients that they were considered operable, they had an operative mortality over 15%. And most of them had still a recurrence within 3 years. Very few patients were alive long term. So that's the reason why doctors in those days, they tried to look for alternative to surgery for the treatment of rectal cancer. And the only thing available at the time was radiation therapy. And in the first kind of iteration of the radiation therapy was the application of radium salts kind of directly to the tumor, either through kind of a prostoscope or inserting small seeds of radium salts or radon gas directly into the tumor. And the first case recorded was treated at MSK. MSK was very instrumental. And there is a link there with Colorado, because one of the members of the board of trustees of the institution was a mining entrepreneur that had mines in Colorado where most of the radium was extracted. So Memorial had a huge amount of radium to experiment and treat a variety of tumors, as you can see in these presentations: tumors in the tongue, in the head and neck, in the rectum, the tumors that were accessible. And this is the first case of somebody cured by radium implants. These are some illustrations of the devices used at the time to treat rectal cancer with radium salts, or again, radon gas in small seeds that they were either placed in the rectum with a device similar to a proctoscope or inserted into the tube, and then with many of them put together in a plaque that was applied over the sacrum to give the radiation to the rectum. And this is just also some illustration from George Binkley, who was the first chief of the colorectal surgery in the 1920s and 30s. And this is the way they used to apply radium. I mean, this is the summary of a presentation that he made to the American Surgical, and a publication that appears in the Annals of Surgery. And it reads, the most effective methods for early cases are radiation therapy, or the combined use of radiation and surgery. At Memorial Hospital, we prefer to use radiation therapy as the principal factor of treatment of rectal cancer. We supplement this treatment with surgery in these cases in which interference offers an additional advantage. I guess that he was probably foreseeing where we're going to be today, because I think we have gone 360 degrees in a century to probably end where people at MSK were in the 1920s. Now, the experience at MSK, of course, evolved from the radium implants and the kind of pretty imprecise way to deliver dose of radiation, delivering radiation with radium salts or radon gas. It was very difficult to quantify precisely, and therefore the treatment, they were not very reproducible. the development of the Röntgen therapy, the X-rays, the way we understand it, developed rapidly and replaced the radium implants that they were used in the 1920s. And from the 1930s on, most patients with rectal cancer at MSK were treated with external beam radiation, similar to the way we treat them today, followed by surgery. This paper from 1959 was a landmark paper. In a large experience of rectal cancer patients, the group at Memorial, Michael Davis and Stuart Kwon, Mauser, Michael Davis and Stuart Kwon, they proved that the use of preoperative radiation therapy was effective, particularly in patients with more advanced tumors. So this paper was the foundation to a number of clinical trials that either use preoperative radiation therapy in all cancers of all stages, or they decided to focus in patients with more advanced disease and use the radiation therapy after the tumor had been removed and the stage of the tumor being known. To make a long story short, this is a table taken from a pretty good review of the early experience with the preoperative and postoperative radiation therapy in rectal cancer. These are the most relevant clinical trials that were inspired by the data at MSK. And they show that radiation therapy given before or after surgery reduce the risk of local recurrence in rectal cancer significantly. Now, it is important to notice that the rate of local recurrence in patients with rectal cancer treated with surgery alone in those days, even in the most prestigious institutions in the world, was still 20%. They were able to reduce it in half, but still the baseline rate was quite high. What this study showed was, while they reduced the risk of local recurrence, the impact on survival was minimal. Radiation therapy did reduce the proportion of patients who die from cancer, but also increase the proportion of patients who die as a consequence of the treatment. So both effects kind of wash off, and the net effect on survival could not be proven by radiation therapy. And I think that is important. Now, having found in the 70s and 80s that the rate of local recurrence with surgery alone was exceedingly high, for a while, during the 1980s and 1990s, surgeons focused in optimizing the surgical treatment of rectal cancer. That's how we introduced the principles of the total mesorectal excision and the cylindrical APR. And I think that's a kind of a spread throughout the world and was adopted by more surgeons treating rectal cancer. So the surgical technique improved significantly. As a consequence, the risk of local recurrence throughout the world kind of decreased in half. This brought the question of whether radiation therapy were going to be effective also when surgery for rectal cancer was optimal and improved the result so dramatically. And that question was addressed by the now famous Dutch TME trial, in which patients that they had been treated with surgery according to the principles of total mesorectal excision were randomized to receive preoperative short-course radiation or not. The study confirmed that radiation was still effective when the surgery was optimal, but again, similar to what had been shown before, not effect in long-term overall survival. Now, we were then left with the question of whether preoperative radiation for all patients was better than postoperative radiation once you knew the pathological stage. And that question was addressed by the German trial. It showed that preoperative radiation was probably more effective and safer than postoperative radiation therapy. Again, no significant effect on survival. So this kind of set what has been the standard treatment for locally advanced rectal cancer for years. Preoperative chemoradiation, TME surgery, and then in some cases, postoperative adjuvant chemotherapy. Kind of this slide summarizes what we learned kind of almost in a century of surgery and radiation in rectal cancer, that the combination of both achieve excellent local tumor control. Still, 25% of patients die from distant metastases. The other thing that we learned is that the combination of radiation and chemotherapy has significant morbidity, impairs rectal, sexual, urinary function, body image, and all these changes affect quality of life significantly. Many patients who go through the entire treatment of rectal cancer with radiation and chemotherapy that were working before the diagnosis return to full employment. This has significant consequences for the patient that last for many years. Now I'm going to touch now basis about the issue of the adjuvant chemotherapy. As I mentioned, the standard treatment includes radiation, surgery, and then postoperative adjuvant chemotherapy. And the reason to use chemotherapy in rectal cancer is because at the end of the day, 25% of rectal cancer patients still die from distal metastases. And if we extrapolate by the benefit that has been proven with adjuvant chemotherapy in colon cancer, well, we have to assume that rectal cancer will benefit because at the end of the day, the tumor seems to be biologically very similar, colon and rectal cancer. Now, the argument against using chemotherapy is because we don't have conclusive evidence from prospective randomized trial exclusively conducted in rectal cancer patients treated with preoperative chemoradiation. So the data kind of is an extrapolation from what we have read in colon cancer. The downside is that chemotherapy adds toxicity. Many of the patients that we treat today, one of the main sources of toxicity is the neurotoxicity related to oxaliplatin. So this is something to keep in mind. Again, the evidence is based on, it's kind of indirect and it's based on meta-analysis on multiple case series and some patients that they were included in colorectal cancer trials. None of them was positive, but the combination of all of this suggested that adjuvant chemotherapy in rectal cancer could reduce the risk of death and the risk of recurrence. But I think the data from that meta-analysis or pool analysis has to be interpreted with caution because the clinical staging in many patients was inaccurate or non-existent. There was a very significant variability in the chemoradiation and radiation regimens, and also surgery in most of those series were not standardized. Having said that, this is a graph survival curves comparing the survival of patients with rectal cancer treated with chemoradiation and TME with or without systemic chemotherapy. And the data from the National Cancer Database suggests that probably chemotherapy might be effective. But others, such as the European groups, doubt that chemotherapy is really effective. This is a pool analysis of 4 major trials conducted in Europe in which they compare disease-free survival and overall survival in patients with rectal cancer treated with chemoradiation and surgery with or without postoperative systemic chemotherapy. Now, the argument against this review is that the adherence to chemotherapy after surgery is quite low because many patients who had gone through chemoradiation and surgery had complications or they are too tired to start chemotherapy when they have recovered from surgery. So therefore, the compliance with the treatment is very, very low. And also some of the criticism to this data was that some of these studies, the chemotherapy use all regimens that they are not what we use today. So, but what can we say about the use of chemotherapy in rectal cancer treated previously with radiation and TME? Is that the compliance is low. Even if you intend to give them chemotherapy, the probability that they will complete the treatment is low. The benefit is at best marginal. The cost, toxicity, and inconvenient. The proof of the benefit of chemotherapy in this patient will require a very large trial. I guess, as I say, the opinions are divided. Some people are in favor of that. Some people still don't believe in chemotherapy after a rectal cancer surgery. Now, for those who believe on the role of chemotherapy in rectal cancer surgery, if we believe that it's effective and that we have a problem in delivering the chemotherapy after surgery, why not give the chemotherapy before? The potential benefits of this total neoadjuvant therapy approach, in which patients will receive both the radiation and the chemotherapy before surgery, is that probably improves the compliance and ensures efficacy. It will treat earlier subclinical micrometastases that are supposed to be the cause of metastasis later on. Again, in the current paradigm of chemoradiation, surgery, and postoperative chemotherapy, patients get the chemotherapy sometimes 5, 4, 6 months after starting treatment. With the TNT, we will be addressing the metastasis up front. Also, the benefit is that enhances tumor response of the primary tumor and reduces the time that patients who had a sphincter saving procedure had to keep the diverted stoma. Now, concerns, it might contribute to repopulation by selecting resistant clones that then won't be killed by radiation. It might reduce the compliance with the radiation. A patient might get sick with the chemotherapy and not being able to complete radiation. One argument is that neoadjuvant chemotherapy has not been proven effective in other tumors. In fact, in some cases, like anal cancer, has been found to be detrimental. And The other issue is that if you use selectively chemotherapy after surgery, some patients might not need it if they have a good response, but if you give the chemotherapy upfront, everyone is going to get it, and you might overtreat some patients. Now, when it comes to delivering the chemotherapy before surgery, we have two choices. One is we can start with chemotherapy, then give the chemoradiation and surgery, finally the last part of the treatment. We can also start with the radiation, then give the chemotherapy and surgery at the end. We call the first approach induction chemotherapy. The second approach is consolidation chemotherapy because it will consolidate the gains of the radiation therapy. But there is a long history of trying to start with systemic chemotherapy, trying to start treating rectal cancer with systemic chemotherapy. There have been a number of small phase 2 trials in the United States and in Europe in patients with very locally advanced disease to try to shrink the tumor with chemotherapy before chemoradiation. What this experience shows is that there was some minimal effect on response, clearly no effect on survival. What it did was to improve the symptoms of these patients. Giving patients with very symptomatic locally advanced rectal cancer, giving them some cycles of chemotherapy, they tend to have a clinical improvement with a couple of cycles. And that's something that has been proven by all these studies, and that is beneficial, but it had not a great impact on the other hardcore outcomes such as local recurrence or survival. At MSK, we started using induction chemotherapy a number of years ago, and a couple of years ago, Andrea Sersek did the preliminary analysis of our cases treated with induction chemotherapy and chemoradiation, and compared the results with patients treated with the standard chemoradiation, surgery, and intended postoperative chemotherapy. What we learned was that the response rate was much higher when we started with the total neoadjuvant therapy compared to the standard treatment. Of course, the compliance, the proportion of patients who completed the chemotherapy was much higher, and there were many more patients who completed the oxaliplatin, and that the time to the ileostomy closure was shorter when you did all the adjuvant treatment upfront. I have just looked at the survival of those patients, and a little bit to my surprise, the survival seems to be the same. The increase in the response rate, which might have benefits, as we'll later see with the organ preservation, didn't translate in an increase in survival. Probably just treating the micrometastasis earlier, you're not going to change the outcome as long as you're going to treat the patient with metastasis once they are diagnosed. So I think it's a little bit of a paradox that we will need to reconcile in the next few years. Same findings have been found in the review of the National Cancer Database experience. Similar to us, they found a slightly increased rate in the pathological complete response, but no significant change in survival. The only prospective trial addressing this question head-to-head was this small study from Spain, in which they compared 50 patients in each arm, the standard treatment with TNT. They confirmed that the compliance with the chemotherapy was higher in the TNT group. More patients were able to finish the chemotherapy as prescribed, but again, no differences in survival. Now, this year at ASCO, the French group present the results, the early results of this trial, in which they compared the conventional chemoradiation, TME, and postoperative adjuvant chemotherapy arm with a new approach that they call TNT, but it's more than TNT because they deliver chemotherapy before radiation, they deliver chemotherapy after surgery, and also they added irinotecan in the chemotherapy. So they changed many things, is kind of a mix pre and post plus irinotecan. What they found is that the PCR, the pathological complete response, was much higher in the so-called TNT arm. In this study, they also found an increase in the disease-free survival in the experimental arm compared to the standard arm. Again, we haven't seen the long-term results, the results on overall survival, and we are waiting for the final publication of this trial. But the results are intriguing. Whether this is due to the fact that they use also irinotecan or is due to the fact that they use the chemotherapy upfront, it still needs to be seen. Now, going to the other approach, starting with radiation and then giving the chemotherapy before surgery, this is a representation of what we did in the timing trial. And I think this design kind of occurred by serendipity, just following some suggestions of the NCI that we couldn't wait too long to do surgery after chemoradiation therapy in patients that they were at risk of distal metastasis. My initial question was, how long can we wait to do the surgery after chemoradiation? So because we couldn't wait too long without any additional treatment, we designed this study in which in each subsequent group, we were adding cycles of chemotherapy after chemoradiation, that way delaying the surgery by a number of weeks. What we observed in this trial was that the rate of pathological complete response increased with the delaying of the surgery and the addition of cycles of chemotherapy after the chemoradiation. We went from 18% to 38%, provide evidence that maybe we were doing surgery and we are evaluating response too early after chemoradiation. These are the results of a similar study conducted in Poland. The group in Poland were very interested in so-called radiation. So what they did is they treat the patient with so-called radiation followed by chemotherapy and compare the results with patients treated with the standard chemoradiation surgery and postoperative chemotherapy. They observe a small increase in the proportion of patients achieving a pathological complete response. In the first publication early on, they found that maybe there was a difference in survival, but long-term, they could not prove that there was a difference in survival between the two groups. Now, again, also this year, the European group have presented the results of the Rapido trial. The schema of the Rapido trial is very similar to the previous Polish trial that I just mentioned. The standard arm, patient received 5 weeks of radiation, followed by surgery, followed by intended chemotherapy. Not all the sites deliver chemotherapy after surgery. In the standard arm, only half of the sites deliver chemotherapy. In the experimental arm, patient received so-called radiation for a week. Then 4 weeks later, they started all of them systemic chemotherapy. Surgery was then performed several weeks later. They also proved, similar to other trials, that with the total neoadjuvant therapy, the pathological complete response doubled from 14 to 28%. Now, the results about survival are more controversial. They based their conclusion on the endpoint that they developed for the study, the disease-related treatment failure. They found a statistically significant difference, but I think the interpretation is difficult because some of the events happened, they were diagnosed earlier in the standard arm than in the experimental arm because there was a difference in timing of the application of the diagnostic tool to assess the tumor response, because also the difference in the treatment. The fact is that there were no evidence of overall survival. And even at 5 years, which is longer than the expected life expectancy in patients with metastatic disease, the two curves are parallel. So we cannot claim that this study has shown a benefit in terms of survival. So if I had to summarize the current data on TNT, I would say that compared with the standard therapy of chemoradiation, TME, and planned postoperative adjuvant chemotherapy, TNT, both of them are associated with higher compliance with systemic chemotherapy, higher pathological complete response rate, not conclusive evidence of improved overall survival yet, and clearly more toxicity because more patients get more chemotherapy and therefore they have more side effects. Now, a different approach. What about using chemotherapy and then don't use radiation therapy? I think there is a solid rationale for that. Chemotherapy reduces recurrence, but doesn't improve survival, which now is the main problem for patients with rectal cancer. Radiation therapy is associated with short-term and long-term morbidity. Radiation therapy enhances all the side effects and all the consequences of surgery. Again, there is a diminished benefit of radiation when you have optimal surgery. And the effect of radiation is questionable for higher rectal cancer. It's probably more effective for the very distal rectal tumor that will require an abdominoperineal excision of the rectum or a very low sphincter saving procedure. But again, it probably had not that much benefit in higher cancer. And then we have never really looked at the effect of chemotherapy by itself on local tumor control. So it was a very powerful rationale. So Deb Schrack, when she was still at MSK, conducted this small study in patients with stage 3 rectal cancer, that they were candidate for a sphincter-saving procedure. They treated them with 6 cycles of FOLFOX. They added bevacizumab. At the time, was very exciting, the use of bevacizumab in rectal cancer in 2 of the cycles. They assessed the response of the tumor to the chemotherapy by flexible sigmoidoscopy and ultrasound. Then they performed a TME. And these were the results. There were 27 patients that completed treatment, and 26% had a pathological complete response. All had an R0 resection. And there were no local recurrence at over 2 months, and only 3 patients with distal metastases. So this preliminary data led to the design of the PROSPECT trial, which is addressing this question in a pretty systematic way. This study has a standard arm, use chemoradiation surgery and chemo afterwards, with a experimental arm or selective arm, in which patients receive a number of cycles of FOLFOX. Then they are evaluated. If the tumor has not responded, then they go to the chemoradiation surgery and more chemo afterwards. But if they have some degree of response, then the patient goes directly to surgery without radiation therapy. The trial has completed accrual. And I think it will be an important trial, because it might change the treatment of a number of patients with rectal cancer, particularly patients with upper rectal cancer. So one of the things that we have learned along the way, and goes back to the days of Janeway and Memorial 100 years ago, is that some cancer seems to be eradicated with radiation therapy. And many of us has been in this situation where you have a rectal tumor, and you give them radiation chemotherapy, take them to the operating room for an APR, and you found that the tumor is gone. And in general, we view that as a good news for the patient, because we have learned that the tumors that have a pathological complete response to radiation and chemotherapy, they do much better than the one that they don't have response. So response is an important prognosticator in rectal cancer today. But the issue is what to do with that. You know, you have a tumor, you give them radiation chemotherapy, you look, and the tumor is gone. Is this patient going to benefit from a TME? That's really a big challenge, and a surgeon's dilemma that I encountered as soon as I went into practice myself out of the University of Minnesota. Now, the challenge is that a pathological complete response is not always equivalent to a clinical complete response. You have patients that appears to have a clinical complete response in the surface, and then when you take the rectum out, there are still nests of cancer cells scattered through the bowel wall. So that is the real challenge, to select patients correctly to avoid surgery. And some people like Angelita Abragama were brave enough to start this approach many years ago. You know, this paper that she published in 2004, summarizing her experience of many years, she compared the outcomes of 71 patients who had what she called a clinical complete response after chemoradiation, and that she just entered into a protocol of watch and wait with the goal of achieving organ preservation, compared the outcome with 2 patients from the group that ended having surgery and had a pathological complete response. And the results were not that different. So what that study showed was that the referral of surgery, just waiting with surgery, was safe. Salvage surgery for patients who developed regrowth was effective, and that the long-term survival with kind of organ preservation was possible. Our own experience at MSK confirmed these findings. This is just the summary of a recent paper that Josh Smith, one of my colleagues, published with over 113 patients followed retrospectively here at MSK. Again, we have approximately 20% of tumor that regrow after a period of follow-up, most of them in the first 2-3 years. And when you look at the survival of those patients and compare with the survival of the entire group, it was not that different. Recently, there had been a kind of an international watch and wait registry, 27 centers in 15 countries. They put together 880 patients entering watch and wait protocol over a number of years. The problem is that we don't know the denominator. We don't know where these patients are coming from, how many patients were treated in all those institutions during that period of time. And also the problem is that there was a huge variability on the staging, how the tumor were staged, on the treatment regimens, how much radiation, how much chemotherapy, etc. How was the response assessed? You know, whether it's a clinical response to me is the same that a clinical response for somebody in Argentina, we don't know. Surveillance protocol, salvage treatment of the regrowths, etc. It was a very heterogeneous population, but surprisingly showed pretty similar results that what we found at MSK. In spite of all that heterogeneity, you know, when you put patients in a watch and wait protocol, you can expect that 25% they're going to grow back. but the overall survival for the entire group might be reasonable because you might be able to do salvage surgery in most of those patients with regrowth. So the key thing in the idea of putting patients in a watch and wait protocol after a clinical complete response is that the criteria has to be set and they have to be reasonable. If you make a very strict criteria and very early on in the assessment, there are going to be a very few patients that they're going to benefit because you're going to take to the OR many patients who still haven't healed completely the kind of the ulcer in the rectum that evolves as the tumor is regressing. And so many patients are going to have surgery, and then you're going to find out that they had a pathological complete response. If the criteria are too loose, and you follow patients that might still have some residual tumor, you might have significant regrowth, and some patients might die from cancer that otherwise would have been saved by surgery. This remains a very important area of research. What really defines a clinical and radiological response? And I think we have some data now. This is a publication by a group of colleagues in Amsterdam, in the Amsterdam Cancer Institute now, in which they evaluated 50 patients approximately 6 to 8 weeks after finishing chemoradiation. And the tools are very simple: digital rectal exam, flexible sigmoidoscopy, and MRI, with both T2W and DWI images. And in this particular cohort of patients, they have a complete response defined a PCR or sustained clinical response of 34%. And as you can see with the ROC curves, the assessment of the response, it was very reasonable. So I think, when you combine all of them, they say that they were 98% correct in predicting a clinical complete response. I mean, this is the way we manage these patients nowadays. Approximately 8 to 12 weeks after finishing chemoradiation or total neoadjuvant therapy, we perform sigmoidoscopy, digital rectal exam, and CEA every 4 months for 2 years, and then every 6 months for 3 more years. The MRI is spaced a little bit more because of insurance issues. We do at least a couple of them a year for the first 2 years, and then every year. And then the CT scan and the colonoscopy just according to the standard guidelines. Now, what have we learned about tumor regrowth in following some of these patients in our daily practice? Again, the rate is going to depend on how strict you are in deciding whether the patient had a real complete response or not. What we have learned is that the regrowth are slow. Most of the time occurs in the bowel wall. We have seen some cases with isolated regrowth of recurrences in the mesorectal lymph nodes, but in general, if the tumor goes away in the bowel wall, it goes away in the lymph nodes. The response is very parallel. And I think more regrowth can be identified early on if you follow the guidelines of timing of surveillance strictly. We have seen that most of the regrowths occur in the first 2 years when the follow-up should be more intense. Now, this is some of the data in the literature. The regrowth rate goes from 15 to up to 34%, and most of them are salvageable. Salvageable means that you can do an R0 TME resection. So again, you're going to have some regrowth, but in most patients, if you are very attentive to the follow-up, you are going to be able to save them. This is a typical case. This is a patient of mine with that tumor. The patient was very interested in organ preservation, so we treated him with chemoradiation. He couldn't get chemotherapy because of issues with neuropathy. That was the first exam after finishing the chemoradiation. A few weeks later, a few months later, the whole thing is healed. Now it's a beautiful white scar. This is what you expect when the rectal cancer goes away. You don't even need to put a tattoo because the scar, for the most part, are really visible. But that was what that regrowth looked like. So in that case, I take a biopsy to prove that, that kind of reddish area that was not there before. And that was tubulobilous adenoma with high-grade dysplasia. Now, when you have this plastic epithelium, it's very difficult to tell whether this is only superficial or deep. So for the most part, we take these patients to the operating room. We did a TME, and the tumor was a T2, because again, what we were seeing was only a little bit the tip of the iceberg. So the tumor just regressed, not in a uniform way, and if you have some epithelial cells superficially, you might have them also in the depth. But this gives you an example of the tumor that we will be doing surgery in most cases of tumor regrowth. Now, what about distal metastasis? Is it possible that some of these patients that had tumor left in the bowel wall for a period of time until they show up a couple of years later can metastasize. And again, in most of these series, most of these retrospective series, including our own, the rate of distal metastasis in patients who had a clinical complete response, sustained clinical complete response, is somewhere between 5 and 9%. Now, if you look at this series from the MD Anderson, where they reported results of patients with rectal cancer treated with chemoradiation and TME and postoperative adjuvant chemotherapy, they stratified the survival by the degree of pathological response. All these patients had TME. You see that the best responders do well, there is intermediate responders, and there is poor responders. They reported the metastasis rate in patients with each one of the levels of response. And even in patients with complete pathological response, they reported almost 7% rate of distal metastasis, which is not that different than what we have in patients who had a clinical complete response. So I personally think that distal metastasis is a different phenomenon that response. Probably that's the reason why sometimes we believe that chemotherapy, for example, total neoadjuvant therapy will be effective when it's not, because I think biologically they are two different processes, and we are looking at that at the molecular level these days. So what can I say as a summary of the watch and wait literature? That I can say that the watch and wait strategy for patients with a clinical complete response to neoadjuvant therapy is safe, but the evidence is based on retrospective case series that report only selected cases. They don't report the entire patient population. The patient population is quite heterogeneous when it comes to stage of the disease and other characteristics. The treatment intention is unknown. For years, we have been doing watch and wait in patients that they were too sick to take them to the operating room anyway. So there are variable neoadjuvant regimens, no predefined criteria of clinical response, and no uniform surveillance protocol. That is the reason why a number of years ago, we decided to start a prospective study, the OPERA trial. And we have a very simple hypothesis. The hypothesis was that a treatment approach incorporating TNT and selective watch and wait for patients with a clinical complete response will result in at least as good or better 3-year disease-free survival comparing with patients treated with a standard treatment arm. And this is the study design. It's very difficult to randomize patients to surgery, no surgery after chemoradiation. So we design a trial in which all patients will receive TNT, will restage after TNT, and then we decide the response or response will dictate whether they have watch and wait or TME. Of course, we have to have historical controls, and we went to our pool of patients to select a kind of a matched cohort of what we expected, considering the location of the tumor and the stage of the tumor, and we use that survival as a benchmark. Now, in our design, we took this opportunity to compare the two approaches to total neoadjuvant therapy. Again, all patients receive neoadjuvant therapy. We randomize half to radiation first, followed by chemo, the other half to chemo first, then followed by chemoradiation, because that was an interesting question for us at MSK at the time. And what we found, to our surprise, is that the proportion of patients who kept the rectum, who didn't need a TME, was quite high. In the consolidation arm, in the group of patients who received radiation followed by chemo, almost 60% of patients kept the rectum long-term. And most of the regrowth, they happen early on. The number of patients who achieved kind of organ preservation in the induction arm was significant, but it was lower. These differences were statistically significant. What we found also is that the disease-free survival and overall survival was similar in both groups. Again, what suggests that the process of distal metastasis is probably independent of the process of response. And that's intriguing, and is something that we need to investigate. Again, the toxicity was significant. Total neoadjuvant therapy causes significant toxicity, and is something that we have to be mindful, because patients, they pay a price to achieve that high rate of response. So what have we learned from the OPERA trial? What we have learned is that a treatment plan that includes TNT and watch and wait for complete responders results in organ preservation in almost half of the patients. Half of the patients with locally advanced rectal cancer can avoid surgery. We found no difference in disease-free survival between patients treated with TNT and selective watch and wait compared to patients who had the standard treatment, which is reassuring, because it was possible that, yeah, we will be achieving organ preservation, but many more patients will develop metastases. That doesn't seem to be the case. It sounds like the order of the chemoradiation and chemotherapy has an impact on the response rate. And I think this, with this design, the radiation therapy first makes sense if you want to achieve organ preservation. So I think, what can I say today as a conclusion of my talk? I think that the treatment is evolving. It has been evolving for over a century. I feel like we are now where we started, when the colorectal service was first created at MSK. We are treating patients with chemotherapy and radiation, and then just salvage those that do not respond. I think that in general, treatment intensification has improved oncologic outcome, but also has increased the toxicity and long-term sequela for the patient, impacting their quality of life. This is very important now, when we are seeing an increase in the incidence in colorectal cancer in patients younger than 50 years of age, that they have a long life as survivors. I think we probably overtreat many patients. I think the trends that you can see today of removing the chemotherapy and removing surgery go in the way of de-intensification rather than intensification. I think probably just in the future, we're going to have not standard treatment, we're going to have probably several standards, and that might have to do with the stage, location of the tumor, goals of the patient. And I think there are many unanswered questions. I didn't want to touch upon today the issue of how we predict which tumor responds and we don't. We are doing a lot of work in the lab. We are trying to take advantage of the accessibility to do molecular profiling of these tumors. And we are trying to harness this molecular biology to develop new, more effective radiosensitizer, an agent that also will treat the distal metastases. I think these questions probably advancing the knowledge about the molecular biology of the tumor and trying to personalize the treatment is what is going to be directing the research agenda in colorectal cancer for the next few years. So again, I just want to thank everyone for the privilege of being here today and for the great honor of giving me this professorship. Thank you so much.
So let me just add in my comments first, and then I'll let John go ahead and run some questions and answers. So first of all, what a wonderful talk. And, I personally have had a lot of contact with the colorectal service at Memorial Sloan Kettering Cancer Center. I spent 2 years there and rotated on Dr. Cohen's service. And I just know all the terrific things going on there, and also the close interactions with the medical oncologists and radiation oncologists. And really the rest of the world looks to what is going on at Memorial Sloan Kettering in terms of how to treat patients. And I'm glad to see all the results and the questions being asked. And I really look forward to learning about the answers in the future. Colorectal cancer, we've made huge progress over the last couple of decades. When I was a medical student, 5-year survival rates from rectal cancer or colorectal cancer were nowhere near as good as what we have now. And it's because groups like yours are pushing the boundaries, and we're learning so much more. And thank you so much for giving this talk. And you have exceeded the tradition of the quality of lecturers here at the Swan Lectureship. So thank you so much.
Thank you. Thank you, Richard. Yeah.
Hey, Julio, thank you very much for the presentation. I just wanted to ask you 2 questions, and I think one is going to be an easy question for you, and one might be harder. First, I'll do the easy one. For that patient from 2015 that had the local regrowth, and that you went ahead and did a TME, based on what we've learned since 2015 with the GRECAR2 and CART studies, would you now offer that patient transanal excision rather than TME?
I think that's an excellent question. Probably to that specific patient, I would. I think we were very overcautious sometimes. I mean, I think that will depend a little bit on what was the stage of the tumor before we started treatment. Remember, in the ACOSOC trial, we did chemoradiation local excision for patients that at baseline staging had no enlarged lymph nodes. So if they were not enlarged lymph nodes at the beginning, I think it's probably safe to do that local excision. If you had a patient who had multiple lymph nodes and the tumor doesn't disappear in the bowel wall, I would be a little bit uneasy, because if the tumor doesn't go away in the bowel wall, what makes us think that it will go away in the lymph nodes? Probably we have some evidence that the lymph node might be a little bit more responsive to the radiation than the primary tumor, but we don't know for sure. So I think you are correct. I think there are a number of patients that probably salvage surgery can be done just by local excision. In fact, there are a group of patients that they have only 2 voluminous adenoma without evidence of tumor deeper down, that we have now, Ph.D, one of my colleagues, is looking at this data, just trying to do just a kind of a endoscopic mucosal resection, so to speak. So I think that's a very interesting question. I think we're going to hear more about that in the future. Just doing salvage surgery by local excision.
Thank you. And then I think the harder question, where there really is no clear answer right now, is with so many options for neoadjuvant therapy, which ranges from doing nothing, based on the Mercury study, and just going right to surgery for certain cancers, where the other end of the spectrum would be long course chemoradiotherapy and 8 cycles of oxaliplatin. I mean, you have this great range of treatments. And I just wonder, which do we choose? In my mind, I feel like the goal is to get a pathologic complete response. And so I want to do the most TNT for every patient, but then how do I balance that with over treating patients? And how do I choose? Yeah.
I think that is the challenge that we are facing today. And I don't know if we will be able to do all the appropriate trials, because the number of patients is limited. And then when you start, parceling out and just doing upper rectal cancer, lower rectal cancer, what I will probably foresee in the future is just considering not only the stage of the tumor, but also the height, the distance from the anal verge, and the patient preferences and expectations. Watch and wait is not for everyone. Some people, they just cannot live with the idea of having left some tumor behind. So here you have somebody, this is a very simplistic way to present it, a patient with a very distal rectal cancer who will require a total mesorectal excision with either a coloanal or an APR. I think that patient, you probably want to achieve the maximal response to get them to the, watch and wait protocol and organ preservation. I think in that patient, in my case, I will start with long course radiation and consolidation chemotherapy. Again, the total neoadjuvant therapy, one of the ways that we approach this thing at MSK, we do frequent assessments of the response. We look after chemoradiation. We look after 2 months of FOLFOX, and then we look at the end. You can always change things. You can stop. But I think if you want to achieve organ preservation, I probably will start with long course radiation therapy based on what we have today. Some people might claim that we can also start with short course radiation. We have evidence that short and long course radiation are equivalent when you do TME, but we don't know the long-term effects of short course radiation in someone who you don't remove the rectum. So I think we have to do some research in that area. But I will probably start with what I know today with chemoradiation, consolidation chemo, with the hope that the patient will be in the 60% that can preserve the rectum. Now, a higher tumor, some really high rectal tumors above the anterior peritoneal reflection, which is a very good landmark. Some of the patients, you just do surgery alone if they are not very advanced. If they are more advanced, we tend to treat them with induction chemo, because that gives you the option of do what the prospect trial is doing. You give them a few months of chemo, you see that the tumor has responded very well. It's very unlikely that you're going to get any added benefit from radiation therapy. So you avoid all that toxicity, assuming that you're going to have surgery. There are some patients with upper rectal cancer that want organ preservation. The benefit of organ preservation diminishes with the distance from the tumor, or the tumor from the anal verge. A tumor at 13, 14 centimeters that you can do a tumor-specific mesorectal excision, avoiding radiation therapy, probably can have a very good functional outcomes. So, and then they avoid the uncertainty and all the other tests. So I think we're going to need to take into consideration all those factors. how big and how extensive is the tumor, where it is located in the rectum, what is the age, the life expectancy, the expectations of the patient. I think it's going to be that type of approach to rectal cancer, which is a little bit unsettling because it's not like you have a guideline. We're going to treat all the patients the same way. So I think that is the view I see the treatment of rectal cancer moving forward. I hope that we can learn more about subset of tumor more likely to respond or less likely to respond, so we can use the neoadjuvant therapy in a much more informed way, so to speak. So that's the way I see it right now, and that's probably the way we practice. Probably you do the same.
Yes.
Yeah.
Thank you.
Thank you so much, Julio, for a wonderful presentation. And we really look forward to seeing the results of some of these trials that you're running right now. Okay. So congratulations. Thank you.
Thank you so much.
Right.
All right.
Okay, everyone. Have a great day.